Hi everyone, thanks for listening to my presentations. Today I'll be talking about Graves' disease, and this will form part 4 of 7 when it comes to hyperthyroidism. If you haven't listened to parts 1, 2, and 3, please kindly do. With that, let's go. Graves' disease. Graves' disease is an autoimmune disorder with the overproduction of the thyroid hormones, giving us hyperthyroidism. Epidemiologically, more women are believed to be affected, particularly in ages less than 40 years old. However, it can affect anyone. The epidemiology is not well described, but most people with Graves' disease will have mild cases, while a very small percentage, about 5%, will actually have moderate to severe disease. It could be bilateral or unilateral extraocular muscle enlargement. What are the possible causes? Of course, autoimmune. Like I've said, autoimmune disease, and is the commonest cause of hyperthyroidism. I have said this in several of my presentations while presenting on hypothyroidism, and even in the last 3 presentations on hyperthyroidism, that when you find an autoimmune disorder in any individual, be ready to look for other autoimmune diseases. So in anyone with Graves' disease, with the background that this is caused by autoimmune condition, we should be checking out for type 1 diabetes mellitus, Sjogren's syndrome, systemic lupus erythematosus, pernicious anemia, Hashimoto's thyroiditis, and the list goes on: ulcerative colitis, Crohn's disease, rheumatoid arthritis, and so on and so forth. Okay, there will be associated thyrotropin receptor antibody, and that will cause overproduction of thyroid hormones. Ophthalmopathy's cause is not very clear or is unknown, but it is believed that there's buildup of certain carbohydrates in the ocular muscle. What are the possible risk factors in Graves' disease? Genetics. And I say it again, genetics. This could be traceable back to the family lineage. There is likelihood of positive family history and certain HLA. Gender. More in women than men. When it comes to age, commoner in women less than 40 years old. And of course, autoimmune diseases. And let me explain further here. I've just said that in the last slide, right? If anyone is having any autoimmune disease and is now presenting with signs and symptoms, pointing to hyperthyroidism, you better think of Graves' disease first. Like someone is down with rheumatoid arthritis or systemic lupus erythematosus or Crohn's disease, and is not having signs and symptoms of hyperthyroidism, rule out Graves' disease. Physical stress, emotional stress, pregnancy, smoking cigarettes, and someone is saying, pause there. How do you mean smoking cigarette? I'm not saying only smoking cigarette could teach anyone to Graves' disease, but if one is having genetic predisposition and the individual is smoking, then the likelihood of coming down with Graves' disease is higher. Poorly controlled thyroid function, and of course, radioiodine therapy. Complications. In pregnancy, any woman that is pregnant with Graves' disease is at risk of possible miscarriage, that is spontaneous abortion, or preterm birth. And if The individual escapes miscarriage or preterm birth. Something else is waiting ahead, like fetal thyroid dysfunction or poor fetal growth, maternal health failure, preeclampsia. All these are possible in pregnancy. Also, later in life, the individual could come down with osteoporosis, and of course, that will predispose to fracture and arrhythmia, congestive cardiac failure. The complication continues as thyroid storm. And when someone has thyroid storm, there will be fever, swelling, vomiting, arrhythmia, hypotension, delirium, severe weakness, seizures, jaundice, coma. In Graves' double-party, that will be a rare occurrence, right? But the individual will have reddish thickening of the skin that resembles an orange peel. And the belief is that there is buildup of certain carbohydrates in the skin. And these will often occur on the shins and on the dorsum of the feet. In Graves' ophthalmopathy, the affected individual will complain about irritation in the eyes. They will complain about excessive tearing, but not just occurring sporadically like that. It will be when exposed to cold air, wind, or bright light. They will complain about retroocular discomfort or retroocular pain. They can have blurring of vision, diplopia, proptosis, and periorbital edema. On physical examination, you can pick lid lag, exophthalmos, lid retraction, inflamed conjunctiva, and stare. Orbitopathy will occur in 20% before the onset of hyperthyroidism. It can occur in 40% concurrently with hyperthyroidism. So, someone having Graves' ophthalmopathy may not have full-blown hyperthyroidism in 20% of individuals with Graves' disease. But majority will have both at the same time, okay? So you've seen a woman with features of ophthalmopathy, Graves' disease, and you do your thyroid function test, and you are not picking hyperthyroidism. That is not ruling out Graves' disease. 20% will present like that. So orbitopathy in 20% before hyperthyroidism, 40% concurrently with hyperthyroidism. 20% in the 6th month after the diagnosis of Graves' hyperthyroidism, we have orbitopathy. So some will actually have Graves' hyperthyroidism diagnosed before the features of orbital problems, right? 10% will not even have Graves' thyroid, but they will have orbitopathy. While 10% after treatment of Graves' hyperthyroidism will then develop orbitopathy. So, post-radiation therapy can teach to that. So, this is saying that just have a clear or open mind when we're dealing with anyone with orbitopathy. Let's be careful. We cannot jump at any conclusion that, oh yeah, that is hyperthyroidism. It should be, but it might not. So it can be before hyperthyroidism, can be with hyperthyroidism, can be 6 months after you've diagnosed hyperthyroidism, and some will not even have Graves' thyroid at all, while it could be after radiotherapy. Diagnosis. We take thorough history of the symptoms, particularly of hyperthyroidism. We do physical examination of the orbitopathy and other clinical features. And of course, we head to lab. What are we looking for? We're expecting thyroid function tests to give us decreased TSH, that is decreased thyroid stimulating hormone, increased T3 and T4, or it might be T4 only in T4 toxicosis and can be euthyroid state, or it could give us feature of thyroid-stimulating hormone receptor antibodies increase. If we have not arrived at diagnosis yet with all those, we can proceed to have radiological investigation done. CT or magnetic resonance imaging could be embarked upon, and other possible tests that we could do that will be helpful will be visual acuity, color vision, and visual field. What are the possible differential diagnoses? It could be myasthenia gravis, it could be orbital tumor, it could be metastasis to the orbit, or statin-induced extraocular muscle myopathy, that is history of statin usage, should be taken here. This could be histiocytosis, could be orbital cellulitis. How about severe obesity? Cushing syndrome is a possible differential, and of course, orbital myositis. What are the clinical features? Gritty or foreign body sensation in the eyes, excessive tearing, like I've said, when exposed to cold, wind, or bright light, blurry of vision, color vision desaturation, might be loss of vision in severe cases. Orbitopathy appears before the onset of hyperthyroidism in 20% of cases and concurrently in 40% of cases, and so on. Treatment. Okay. We have to go back to the previous presentation that I've published, and that is the treatment of hyperthyroidism. Please check that out. I will not go over all that here, and please don't miss out. Check that out and then come back and check this slide, or you check this slide now, and when you're done, check the treatment of hyperthyroidism. Okay, then you can apply all the steps as per the treatment of hyperthyroidism right here. But in addition to that, you can have lifestyle changes like reduction of weight in obesity, smoking cessation in anyone smoking. They can use sunshades, artificial tears, you should raise the head of the bed at night. Dark glasses will be helpful, okay? Methylcellulose drops, petrolatum jelly at night, and eye patching or prisms. Still part of the treatment is selenium, 100 microgram twice daily for 6 months if you're dealing with mild Graves' disease. Can give glucocorticoids, for example, prednisone per oral, or intravenous methylprednisolone. Mycophenolate mofetil could be used, interleukin-6 antibody, and octreotide. Still on treatment, insulin-like growth factor 1, teprotumumab. In ocular emergency, we can give dexamethasone 4 mg intravenously, orbital decompression surgery, and external orbital radiation. With that, I've come to the end of this very presentation. The next presentation will be on thyrotoxicosis, and that will form part 5 of 7 as per hyperthyroidism on my channel. Please kindly remember to subscribe and share. I appreciate it.